Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Thank you. I thought I'd just recap initially a bit about, and please let me know if you can't hear me properly or you can't see the slides or something, but yeah. So I thought I'd maybe recap from a few weeks ago now, a little bit about the presentation that I gave last time on methotrexate. So we'll just kind of cover what methotrexate is a little bit, and it's, as I said last time, it's a disease-modifying anti-rheumatic drug, and the main thing I wanted you guys or everybody to kind of understand was that it's not an immunosuppressant medication. It's more of an immunomodulatory medication, and it kind of says that in the name. But there is a bit of a misconception or concern in the general community that it suppresses your immune system, and hopefully that will have laid a bit of that stress or that angst about that a little bit from last time. In terms of why we or how we use it, there's a couple of things. Firstly, the why, it's mainly to reduce inflammation, and the way that it does that is by blocking an enzyme called dihydrofolate reductase. Now, please don't lose any sleep over the pathophysiology of this because it's pretty boring, but this is how it works, and it is what it is. But we know that by doing so, it does reduce inflammation, and ultimately the reason why we use it is because by reducing inflammation, we can get rid of pain, we can get rid of swelling, stiffness, all of those symptoms essentially of inflammation. And there's also secondary benefits as well in terms of reducing the risk of things like heart attacks and strokes and issues with osteoporosis. So it's not just a joint disease or rheumatological joint diseases are not treated just for the joints. It's more for the overall health of people. In terms of when we use it, I mentioned a couple of indications. Essentially, usually it's when we know that there's peripheral joint inflammation, and I use that term as meaning inflammation in joints like the ankles, knees, wrists, so anything that is sort of essentially in your limbs, really. And that's like conditions in rheumatoid arthritis, psoriatic arthritis, in SLE or lupus, or sometimes we can use them in conditions that we, as rheumatologists, label as polymyalgic onset of rheumatoid arthritis, so PMR onset of RA. And sometimes even in people with PMR, if they do not have tolerance or they don't tolerate prednisolone long-term very well, or they've got other reasons why they shouldn't be on steroids for a long period of time. I might cover this a little bit more in tonight's presentation in terms of how we use it, because I understand there was a lot of chatter in the chat essentially last time as to how it's used and different ways that people can take methotrexate, how often, folic acid, and so forth. So I'll go into that a little bit more. But again, I want to stress that this is a medication that doesn't work very quickly. It's something that works slowly, in fact, and can take up to 3 months, we generally say, for it to take full effect. Sometimes, in my experience with my patients, it takes about more than 3 months, so maybe 4 or 5 months, but we generally don't leave it for much longer to sort of decide whether or not it's effective or not. So next slide, please. Thank you. The other thing that we'll kind of go into a little bit more, because I know that a lot of people get concerned about the side effects or possible side effects to methotrexate, and we'll kind of go through the common and less common ones and why some of those might actually come about, as well as how we monitor patients. So I mentioned last time that we generally do blood tests pretty frequently initially when somebody starts on methotrexate, and that's just to monitor things like their full blood count, to look at bone marrow suppression, liver function tests, kidney function tests, and of course the inflammatory markers, which are the ESR and CRP. But as the condition becomes a bit more stable and hopefully quiet, and people don't have symptoms, and their initial blood tests don't show any side effects, at least from methotrexate that we can see in the bloods, we do the blood test less frequently. For some conditions, particularly rheumatoid arthritis, because we know that there is an association between lung disease and rheumatoid arthritis, I generally get a chest X-ray for anyone who is initially diagnosed with rheumatoid arthritis and then goes on to have methotrexate on board as well. So it's not so much because methotrexate causes lung damage that the risk of that actually happening is very, very low. It's more because of the association with rheumatoid arthritis and lung disease that I do a chest X-ray. We'll cover a lot more about special circumstances where methotrexate needs to be considered, and I touched on previously, family planning and alcohol and vaccinations. But tonight we'll cover a bit more about supplements and other medications, which I know a lot of people had questions about, and just in general, there's a lot of supplementation that is taken in the community and other medications for other medical problems. So we'll go through that a bit more as well, and then certain conditions in which methotrexate needs to be paused. So usually not conditions, medical conditions, but circumstances like surgery, for example. Next, please, Sarah. Thank you. So in terms of how methotrexate is taken, there are two ways that it's taken. The first and the most common way is orally. So PO is per oral. And you guys might have, if any of you are on methotrexate, might have seen this bottle, which is a methotrexate essentially bottle. That's what the container actually looks like, and it's a 10 milligram tablet that we have in Australia. I know I've got a few patients who have come from overseas, and some of the strengths that they have in other countries include 2.5 milligram tablets, but we don't have that in Australia. So the minimum dose is 10 milligrams. And the main benefits from that is that it's easy to take. Obviously, it's a tablet, and it's easier to remember to take because often people are also on other medications, so that makes it easier to just kind of, I guess, put in a Webster pack or lump together when they take their other medications. But the downside is that sometimes people can get gastrointestinal or GI type side effects. So I mean, nausea, vomiting, diarrhea, and obviously because it is another tablet, the pill burden increases a bit. Mind you, it is a once a week tablet, so it's not a massive pill burden, but of course for some people who, and I've got a lot of patients who've gone from no medications to all of a sudden being on methotrexate and folic acid, so it does seem like quite a lot to take compared to the usual. The other main downside is that because it is broken down by the liver, just like most other medications, there's really a little bit less of the medication itself, the active drug, that gets into the joints to kind of take effect. So you're not really getting the full dose, I want to say. The other way that methotrexate can be taken is subcutaneously, so that's SC. And I've shown here a diagram or pictures of what the different syringes look like, and you can see that they come in different strengths. That's why they're different colors. In Australia, and some of you who might be on methotrexate injections, it's called TrexJet. The benefits of the injections are that obviously it's not a pill, so it's less of a pill burden. And there should be less, but not necessarily 0% risk of potential gastrointestinal side effects, but certainly should be a lot less than the oral route. And because it is not broken down by the liver as much, your joints should be getting a bit more of it. So you're not, for example, if you're prescribed 20 milligrams per week, you might be getting a little bit more than 20. But when I say that it's not broken down by the liver, I don't mean that it becomes toxic. Like the drug is still metabolized safely and properly by the body so that you're not getting toxic levels. The main downside is that some people are really not injection people. Some people just will faint at the sight of an injection, or they're worried about getting injection site reactions. But I guess one of the things to reassure people is that the needle actually is not, the device itself, or the syringe itself, is not very big. It's probably the same size, I would say, as, or maybe a little bit bigger than the flu vaccine that you might get, and your GP puts it in your arm, but this is something that you would put yourself in your tummy, where there's a little bit of fatty tissue, or in the thigh, and you kind of alternate it around so you don't get a bruise. And in terms of possible other side effects that are not related to gastrointestinal things, the risk is still pretty much the same as if you took a tablet. In terms of the dosing, as I mentioned, the tablet itself comes as a minimum of 10 milligrams per week. Sorry, 10 milligram tablet strength, I should say. And you might see on the prescription, and there's been a few changes in the last probably, I want to say 12 to 18 months. Normally, the prescription that we provide is a quantity of 15 with 3 repeats. So that should still be quite would last a long time. But recently I've been told, the pharmacies have run out of that particular type of quantity, and they only had the 50 quantity with 1 repeat, which lasts even much longer. But that's kind of what the prescription would sort of look like. And for myself, my approach, and this is not everybody does this, but I generally start with 10 milligrams per week, but I only do that for about a week just to test out for people and see how they tolerate it. And then after that, I go to the maximum dose, which is 20 milligrams per week. That would be the same dose whether I did oral or subcutaneous administration. So next slide, please. Thank you. In terms of folic acid, which you'll often see associated with methotrexate, the reason for that is really pretty it makes sense, really. So when you think about folic acid, it's a synthetic version of folate or vitamin B9, and it's usually found in certain foods. And you think about leafy greens or legumes, or even some fruits like bananas contain vitamin B9. But the body needs folate in order to make new blood cells and DNA. So the way that actually methotrexate works is that it reduces folate in the body by reducing its stores, and so therefore you can become folate deficient. And the body can't store enough of the folate on its own, so to counter the effect of methotrexate, and so that's why supplementation is needed. So I think I've had a lot of patients who said to me, look, I have a lot of leafy greens, or I'm a vegetarian or I'm a vegan, so do I actually need to take folic acid? And my answer is still yes, because the amount that you actually get in the tablet is a lot more and helps with replenishing the stores compared to what you could actually do just purely by diet. And this is in terms of countering the effect of methotrexate. But usually 1 day a week of folic acid, and the day after methotrexate is all that's required. We generally don't recommend that people are on it take it the same day as methotrexate, mainly because a lot of people find that they get sick just because of the way that the methotrexate gets broken down and how folic acid kind of fits into that flow of metabolism. People can feel sick if they take both of them together. So you should just take it 24 hours afterwards. There's no right or wrong in terms of either when to take methotrexate, as in what time of the day, or when to take folic acid, but as long as they're 24 hours apart, it should be fine. When you think about folate deficiency, some of the symptoms that people can experience include things like anemia, mouth ulcers, or reduced sense of taste, diarrhea, sometimes lack of energy as well, or often it's lack of energy. And so, I don't know if that sounds familiar to most people, but actually that's where some of the side effects kind of come from. It's because of the folate deficiency. Next slide, please, Sarah. So, I spoke about last time some of the side effects or possible side effects of methotrexate. And I always say possible before I say side effects, because it's not a guarantee that if you start methotrexate, you're going to have any of these side effects or all of them. Most of the time, and generally it's well tolerated, but the common ones are the possible nausea, vomiting, diarrhea, hair thinning or hair loss, mouth ulcers, fatigue for the first 24 hours of taking it. And again, I'll touch a bit more about this in a few slides' time. And some of the other possible side effects that I mentioned last time was bone marrow suppression. So that means your white cells, your hemoglobin, your platelet count can drop just because of the way that methotrexate and folate actually is important, or I should say folate in particular is in the body, and the liver function or LFT is becoming deranged. And just like with any medication, you can get a rash and headaches, and not very commonly, but sometimes you can get overwhelming fatigue to the point where it affects your quality of life and function. Next slide, please. There was an interesting question in the chat last time about what the difference between folic acid and folinic acid was. And essentially, they're both forms of vitamin B9, but the way that they differ is in their chemical structure and how the body actually processes them. So folic acid is a synthetic form, so it's like not naturally occurring essentially, whereas folinic acid is a naturally occurring active form, and that's the one that the body or your body actually processes it or can, I guess, tolerate when it consumes food that's got B9 in it. Essentially, in terms of the differences in how it's used, there's not really, or how it works, there's not really much difference. Folic acid is just as effective in terms of reducing possible side effects, particularly when it comes to gastrointestinal side effects and bone marrow liver derangements, as folinic acid. But it's just cheaper. So we know that there's a lot of studies that have been done that looked at folic and folinic acid in terms of reducing side effects, and they found that the rate of gastrointestinal side effects and bone marrow suppression is less with either of them. Fundamentally comes down to almost economics, really, doesn't it always? Folic acid is much cheaper than folinic acid. So we generally reserve folinic acid for patients that have certain types of side effects. And they're usually pretty bad side effects, to be honest. Like if they've got really bad mouth ulcers, or if they've got bone marrow suppression, really bad liver function tests, because essentially the ability of folinic acid to actually reach a higher level of concentration in the blood to actually counter the effect of the methotrexate that's caused those problems is a lot more than folic acid. And as I said, it is more expensive. So when you think about it, I'm not sure if anybody has tried this, but you can actually go onto the PBS online website and you can search for different drugs that you're on and see how much it costs and things like that. Obviously take into account that individual pharmacies might price their products differently to what the PBS says. But even just from the PBS online website, you'd pay $95 for just 10 tablets, which is the maximum amount that you could be dispensed for folinic acid, compared to $20 for 100 tablets. So when you think about it, if the two work the same, they're just as effective as each other in normally and under the same circumstances of being used with methotrexate, then you'd pay $20 for 100 tablets rather than $95 for 10 tablets, if that makes sense. So really, I want to sort of make it clear that, folic acid is completely safe, and generally it's pretty effective in taking, or is effective in terms of use with methotrexate when you take it 1 day a week, the day after, and it will reduce possible side effects from methotrexate. So you don't really need routinely to use folinic acid unless you're really unwell, and your doctor would generally let you know that that's what you need to be on.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.